M. Murlidhar Pai sir. I heartily welcome everybody. Dr. M.G. Hiramat sir, the chief patron, Dr. Nagraj sir, the president, Dr. Vidya Thobi ma'am, Suman Gaddi, treasurer, and the dean of KCOG, Dr. Hema Divakar ma'am, Baswaraj Sajjan sir, Vidya Bhatt, and our esteemed speaker for the evening, Dr. Pratik Tambe, who has taken a time off from his busy schedule and accepted our invitation and been present here to talk about a very interesting topic, that is chronic endometritis and its impact on fertility. I heartily welcome all the members and the delegates who have logged in for today's evening and today's webinar for a short, crisp, yet very important clinical subject on chronic endometritis in infertility. Over to you, Pai sir.
Okay, good evening and thank you, Dr. Rajeshri. And I am so happy that today we have a special speaker, Dr. Pratik Tambe, a good friend of mine from Mumbai. Infertility is a very, very common topic nowadays, but this particular aspect of infertility, that is endometritis, chronic endometritis, how it impacts infertility is an enigma still to be explored. We have almost conquered ovulation induction. We have conquered fertilization. We have conquered almost, the embryo transfer techniques and everything. Yet the endometrium holds the key. It may reject the embryo that we have transferred. So nowadays, the infection part of it, especially the chronic one, is coming up in a very big way in the failure of implantation. And who better than Pratik Tambe to speak on this? Arun, can you put his CV? Yeah. So I would like to introduce Arun Tambe, though this may not be an exhaustive introduction. He is an ART consultant and gynae endoscopic surgeon at Ashirwad IVF, Mumbai. International diploma in advanced laparoscopic surgery from France. Trained in assisted reproduction in Belgium. Incidentally, I also had the training in the same place. Trained in clinical embryology and ICSI at London and Singapore. He is a very active member in FOXI and its affiliated societies. He has been the chairperson of AMOGS Endocrinology Committee in 2024, governing council member of ICOG from 2021 to 25, patron and managing council member of Mumbai OBGY Society, that is MOGS, in 2013 onwards, managing committee member of Indian Society of Assisted Reproduction, that is ISAR, from 2020 to 24, managing committee member of Maharashtra chapter of ISAR, and also past chairperson of FOXI Endocrinology Committee, during which he has conducted countless webinars, conferences, CMEs, etc. He is the recipient of 30 MOGS, AMOGS, ISAR, and FOXI prizes and awards, which speaks for his credibility. He is the editor of 24 books, 4 FOXI focuses, and handbooks, 11 key practice points. He has contributed 100 plus chapters. In fact, I have requested him to contribute a chapter for my book recently. He never says no for anything that anybody asks for. And he is the convener of ICOG Reproductive Medicine course and peer reviewer in Journal of Obstetrics and Gynecology of India, that is JOGI, from 2012 onwards. Dr. Pratik, I am very thankful to you for accepting this invitation, and I request you to deliberate on the topic of the day. Over to you, Pratik.
Let me begin by expressing my gratitude to Dr. Murlidhar Pai for that exhaustive, elaborate introduction, and also for inviting me to this very prestigious forum of CPAP. I also need to express my gratitude to all the office bearers of KCOG as well as Kasuga, Professor Hiramat, Dr. Hema Divakar, Dr. Basavaraj Sajjan, Dr. Vidya Bhatt, and of course my dear friend Dr. Vidya Thobi as well. So thank you very much everybody who is present here. I am here to talk to you about chronic endometritis, and you may have heard speakers deliberate about this earlier. But let's try and put a different perspective on it. Let's try and talk about it in a different way. And let's try and address it in a practical fashion. Because when you start talking about theory, it's something which is exhausting and it is never ending. I start with quotations, and today's quotation is from a famous ballet dancer. And she actually suffered a spinal cord injury. And because of this, her chief passion in life is something which she could no longer follow. And Jennifer Stasek once said, I often wish that more people understood the invisible side of things. I've tried to structure this presentation in the following format. First, we look at what is endometritis. How is chronic endometritis unique? The principles for appropriate and timely diagnosis, the impact on fertility, which is all important and actually the subject matter for discussion, the tenets for successful management from a clinician's point of view, and finally, the cutting edge therapies for the
ಸಿಕ್ಕಾಪಟ್ಟೆ ಆಪ್ಷನ್ ಇದೆ. ನಾಲ್ಕು ಸಾವಿರದಿಂದ ಶುರು ಆಗಿದ್ದು ಒಂದು 17,000-18,000 ರೂಪಾಯಿ ತನಕನೂ ಇದೆ.
May I request everybody to mute, please?
Arun, can you please mute Dr. Nagraj?
Yes, madam.
Yes.
Right. So whenever we talk about a topic, it's important to first start by being realistic. And by being realistic, I mean we need to ask ourselves whether this subject that is being deliberated, is it clinically relevant? Is it something of practical importance? Or is it just something which is there to fill a slot in a conference and it is highly theoretical? It won't have any practical impact on your clinical practice when you go back home. It's just good to know, but maybe it won't impact clinical practice and patient care in day-to-day practice. So when we talk about endometritis, there are a number of references which are available both in Indian as well as Western literature. I'll show you these references as time goes by. The first and most important of these is a publication in Fertility Sterility in 2018 August. This is from a Japanese group which talks about endometritis, new concepts, new time, and a lot of the genetic and molecular basis of how endometritis affects implantation is explained in great detail in this particular paper, which we will come to in just a couple of minutes. There are also other wonderful publications, including this one, which is from, I think, Italy and also from France. And this looks at the endometrial causes of RPL, which includes chronic endometritis as well. So let's start with a basic primer. All of us know that endometritis by definition means that it has to be an infectious and an inflammatory disorder of the endometrium. This can be of acute onset or it can be chronic. Acute PID is something which we all are familiar with and we've learned about it since our undergraduate days when we read our Jeffcoat and Shaw. So I'm not going to repeat that. But what we are trying to focus on here is chronic endometritis. And the key point which I want to drive home here is that it has no associated symptoms. In fact, one of the major reasons why it goes undiagnosed is because there is no clinical presentation. Often the first presentation to the clinician is that the patient says that I'm unable to conceive and the presentation is actually infertility. We know that acute PID leads to salpingitis, blocked tubes, and failed fertilization, whereas chronic PID leads to salpingitis, endometritis, a thin endometrium, and recurrent implantation failure, all of which present to you directly or indirectly as primary or secondary infertility. What is important to know is that for a diagnosis to be made, the gold standard is a histopathological diagnosis. And on histopathology, the acute inflammation results in a microabscess formation, there's neutrophil infiltration, and there are going to be defects in the lumen and the gland of the uterine cavity. Whereas chronic endometritis is completely different on histopath. There is an endometrial superficial edematous change. There's an increase in the stromal cell density. There's going to be dissociated maturation between epithelium and stroma. And the most important line is that last line on that slide. There is infiltration of something called as endometrial stromal plasmacytes, or ESPCs for short. Now, these ESPCs are a recurrent theme when we look at chronic endometritis. In fact, in ordinary H&E stains, which you and I have done in first and second MBBS, these are not going to show up. You need special staining techniques, you need supervising stains for these to show up, and we will come to that in due course of time. But these ESPCs are the ones which are pathognomonic of chronic endometritis, infection, and you need them for a diagnosis to be made, a tissue diagnosis. What are the organisms responsible? Again, there's a long list which all of us is familiar with, right from Streptococcus and E. coli all the way to foreign bacteria and Pseudomonas gardnerella. The most important organism which is not there in the list, I put up a picture on the right side. No marks for guessing. It's a rod-shaped bacillus, doesn't get easily stained, and it is called as Mycobacterium tuberculosis. The most common cause of chronic endometritis in our country, and very uniquely only in South Asia. You will not see this very commonly in the Western world. Therefore, there are not many references to MTB specifically causing chronic endometritis outside of papers which have origin in South Asia. You'll see a lot of papers listing out all of these organisms on the left. Most of our classical textbooks also refer mainly to all these species which you see in this list, except MTB, and we'll come to MTB, of course, in due course. So the million-dollar question of the day, why is chronic endometritis specifically relevant in our discussion today and to day-to-day practice as far as infertility is concerned? And the simple reason is that most of our patients present late. This results in a failure of diagnosis by the clinician because we ourselves have a low index of suspicion. We don't think of chronic endometritis. We don't think of Mycobacterium tuberculosis until the patient either has a recurrent implantation failure, multiple failed IUI or IVF cycles, and then we feel that there must be something wrong with the end organ, which is the endometrium or the residua, and we go ahead and do a biopsy or we do different tests, which we will of course cover later on in this talk. And that is when we fail to realize that, okay, all this time this patient had chronic endometritis, we failed to diagnose it, and we could have shortened what is called the time to pregnancy if we had diagnosed it in the first place. So because we failed to diagnose it, we do not institute the appropriate therapy. And as we'll see in just about 5 or 10 minutes, the treatment is very easy. The treatment is not difficult. The treatment results in very good cure rates and excellent outcomes. The problem is we don't think of it. We don't actually approach it in the right fashion. And because there's a failure to diagnose and treat, therefore our patients suffer. There's also lack of knowledge about new concepts, and those new concepts will be the last part of this talk. So what is the best tool for diagnosis? Obviously, as we just said a couple of minutes back, you need to have a tissue biopsy or a histopathology with special staining techniques, which will identify something called as ESPCs. And this is beautifully laid out in a paper from Poland, which says chronic endometritis, is it time to clarify the diagnostic criteria? This is published in 2023. All of these papers are freely available on the internet. If you can't find them, if you're unable to locate them, send me an email. I'll share all these references with you. So what they've said is that the number one way in which you can diagnose CE is the presence of multiple ESPCs. And you can see those with those blue arrows in the picture on the right. The problem is that you need an endometrial biopsy for this. It's not going to show up in basic ultrasound or simple, how can I put it, pap smears. You need to do an endometrial tissue biopsy to diagnose these. These are rarely performed in gynec practice. Again, another major hurdle is that we don't have enough knowledge as well as trained cytopathologists who will look for these ESPCs. And if you look at chronic endometritis and you look at tissue biopsies, failure of diagnosis often is not only because of us clinicians not thinking of this diagnosis, but also because we don't have adequate laboratory backup and trained pathologists who can pick up this condition. Again, there is another issue that there is no universal agreement between pathologists themselves as to what constitutes the perfect criteria to diagnose CE. But what is known is that there are various different microcellular alterations which occur in CE. And these include your altered cellular populations and cytokines. There is B cell infiltration in the regenerating basal layer of the endometrium or stratum basale, as we once learned in our first MBBS. This spreads to the granular lumen, which is pathognomonic of an infective and an inflammatory pathology. There is a lower percentage of CD16 negative and CD56 bright natural killer cells. There's increased population of T cells. The adhesion molecules and chemokines which are required for B cell extravasation, and those are the different molecules which are listed in the brackets. Very honestly, I myself am not familiar with them, but if you're a student and you're listening to this lecture, you put this in your exam paper or you explain this during your Viva, I'm pretty sure even your teachers will not be aware of this. TNF alpha and immunoglobulin populations are also raised. There's also abnormal gene expression, and this is something which is more tangible and which is more relatable for us clinicians. What we find is that certain genes are upregulated and other groups of genes are downregulated. The upregulated genes include BCL2 and BAX, which are anti-apoptotic genes, and there are also increases in the ovarian steroid receptors, which is the estrogen receptor A and B and progesterone receptor A and B. The proliferation associated nuclear marker Ki67 is also increased. In contradistinction, you find that certain genes which are associated with embryo receptivity and decidualization, both of which are important from the implantation point of view, are downregulated, which include your interleukin 11, CCL4, IGF1, Cas8, and of course your PRL and IGF-BP1, which are important markers which are coming up in a big way in research, especially if you read Western papers. We don't have so many centers in India which are capable of giving you these particular genes and they are mapping them out and giving you the relative proportions, whether they're up or down regulated. But I'm pretty sure very soon India will also have the capability to have such kind of advanced labs and pathologists who will give us these insights. This is an important slide because this is actually the crux of all the tests which are used for diagnosis. And this talks about Syndecam-1 or CD138. This is a transmembrane heparan sulfate proteoglycan, which is involved in both cell-to-cell as well as cell-to-matrix adhesion. And this expression is observed on the cell membrane of plasma cells. So your ESPCs, which you saw in 2 or 3 slides back, these are stained with supravital staining, specifically targeting this CD138. And this is the basis for your immunostaining techniques. So if you have a particular stain which attaches itself to CD138, you can identify your ESPCs very easily. And the moment you see ESPCs in a tissue sample, that is when you have diagnosed CE above and beyond any sort of doubt. A couple of slides about the role of hysteroscopy because I'm also an endoscopic surgeon and I like working with my hands, not just talking about theory. So office hysteroscopy has now come of age over the past decade or so. It utilizes something called as a see and treat approach. And on hysteroscopy, which is done immediately post-menstrual, you will see multiple changes which occur in patients with CE. This includes endometrial micropolyps, which are 1 to 2 millimeter small protrusions arising from the endometrial surface. You can also have stromal edema and thickening, and you can see these in about 11% of women who are undergoing hysteroscopy for chronic CE. Even without taking a hysteroscopic directed biopsy, just on visualization, you can diagnose CE with a simple office hysteroscopy. Patient is awake, does not require anesthesia. It can be done in 5 minutes as an office procedure, and patient goes back at the end of the procedure, back to work status. And you can identify this in 50 to 67% of women who have both recurrent implantation failure and recurrent pregnancy loss, specifically which occurs in the first trimester. The other markers on hysteroscopy are strawberry aspects, which we've seen quite frequently both in acute as well as chronic endometritis. There are hyperemic areas with a central white point. And if you go close to it and you have water pressure, then that white point typically shows you blanching, just like you have in spider nevi, which are seen in liver cell failure. And in 65% of women who have histopathology confirmed CE, you will see these on visualization with a simple office hysteroscopy. Overall, you will find that hysteroscopy has a sensitivity of up to 54% and a specificity of up to 94%. But it cannot give you a 100% confirmation because for that, you need CD138 immunostaining of ESPCs and endometrial histopathology biopsy is of paramount importance. Again, we do not have too many trained cytopathologists doing immunostaining in India. So to what extent we can implement this in our clinical practice, your guess is as good as mine. But hopefully over the next 5 to 10 years, we will have these capabilities as well. While I was studying to prepare this presentation a couple of months back, I came across this very interesting paper. And this actually showed us that there is a working group for standardization of chronic endometritis diagnosis. Now, this came as news to me because I was not aware that there is any such working group or there is any such special interest group. And they reached a Delphi consensus, which said that you need to have at least one of any of these 5 or 6 different findings on hysteroscopy to give you a 100% diagnosis of chronic endometritis. These include all the different things that we've talked about in the preceding 2 slides: strawberry aspect, focal hyperemia, hemorrhagic spots, micropolyps, and stromal edema. Out of these, the micropolyps and the stromal edema are the ones which are easiest to pick up, and even a novice who is doing opistoscopy for the first time can pick these up very easily. So are there any predisposing factors which we have been identified? Yes, we know that bacterial vaginosis, endometriosis, endometrial hyperplasia, all of these conditions are associated with chronic endometritis. And we know, of course, that tuberculosis in this country is pretty rampant even today. And today it takes the shape of not primary tuberculosis, which is lung tuberculosis, but it can present as abdominal or it can present as genital pox as well. Genital tract dysbiosis, a couple of slides, because this is emerging in a big way over the past 4 to 5 years. We know that the genital tract, both the vagina as well as the uterus, have a lactobacillus dominant microbiome, where lactobacilli are 90% or more of the bacteria which are present in the genital tract. And this is more favorable for success in both IUI cycles as well as IVF-ET cycles. Now, obviously, in clinical practice, we don't do tests to identify whether the microbiome is lactobacillus dominant or not. But if you see at any point of time that the patient has a chronic cervicitis or she has a discharge, then that needs to be treated, and a co-prescription trying to restore the balance in favor of lactobacillus dominant microbiota is something which is emerging in a big way as treatment, both before your treatment cycle as well as in patients who have multiple failed cycles. As you can see, non-lactobacillus dominant microbiota are associated with poor reproductive outcomes, including implantation failure and pregnancy loss as well. So what is the link between CE and reproductive failure? We've covered this directly and indirectly. This is one slide which summarizes everything in a very short way, and I won't go into much details. I'll cover only the basic headings. You're going to have an altered autophagy, altered apoptosis, altered endometrial genetic expression, impaired vascularization, poor desfibrillation, changed microbiome. Uterine dysperistalsis is something which we've not talked about, but that is emerging as one of the major ways in which embryo rejection takes place. We know that there are multiple cytokines and inflammatory markers. The populations are altered, which happens at the level of the decidua. And all of these directly and indirectly combine to ultimately result in reproductive failure. There is an accumulating body of evidence which says that CE is diagnosed in about 28% of patients who have unknown causes of infertility or, in inverted commas, unexplained infertility. Up to 41% of patients who have RIF have coexisting CE. Up to 28% of patients who have recurrent pregnancy losses, especially first trimester losses, have CE. And when you look at infertile women who have CE, the clinical pregnancy rates are significantly lower if these women are not treated. In fact, if you leave these women alone, you will find the live birth rates are only 7%. And as I'll show you, once these women are treated, there is a huge increase in the success rates. Does it lead to obstetric complications? You'll be surprised to know that yes, very much it does. Chronic dysuria is linked to preterm labor. It's not rocket science, it's just common sense, obviously, because those microorganisms are always there. They are colonizing the chorion and the amnion, and ultimately the chorionitis is going to result in preterm labor. There's also colonization of the umbilical cord and ultimately results in infection of the fetal brain, resulting in cerebral palsy and neonatal periventricular PVML or leukomalacia in up to 20% of babies. The standard treatment regimens are known to all of us. These are very similar to the CDC guidelines for chronic PID, doxy plus metro, given for 14 days. 99% cure rates for ESP3 if you do an endometrial biopsy after treatment. The alternative, if the patient is intolerant to doxy, is to give ofloxacin plus metro. Of course, if it is a biopsy proven Mycobacterium tuberculosis, then EPT with 4 drugs, EHRZ for 2 months plus another 6 to 9 months of HR is recommended. What is also important to know that there is now an emerging concept of multi-drug resistant chronic endometritis because these organisms have been harbored in the body for years together. They may also be resistant to more than one course. In fact, if you have resistance to 2 repeated courses of these standard regimens, then it is recommended that you do a smear culture antibiotic sensitivity and then try and weed them out with specific antibiotics which are targeting that particular resistant species. This is a beautiful paper which I saw, and this is published from Spain in RBM Online. This is 2021 May, and this looks at the impact of chronic endometritis on infertility, which is the subject matter of today's discussion. A very busy slide. This is an analysis of multiple different studies which are presented over time. It's impossible to read, so I've summarized it in one single sentence on the next slide. And it says very simply in its conclusion that treatment with antibiotic therapy yields an estimated cure rate of 88% in the infertile population. Now, the impact of this may not be very apparent to you, but if you think about the couple who has undergone years and years of infertility treatment, multiple cycles of IUI, multiple cycles of IVF, numerous hysteroscopies, laparoscopies, they are running from pillar to post from one clinician to other and trying to achieve a pregnancy, especially in today's world where surrogacy is not possible, next to impossible. Donor aggregate has become very difficult in the new ART era. Women want to conceive and try and have their own genetic child, and they want to give birth to their own babies. Remember that a simple diagnosis of CE and treatment with antibiotics yields excellent cure rates. And in fact, it also includes fertility. To what extent? You'll see that in women with recurrent implantation failure, if you do a day 3 embryo transfer, there's an improvement in live birth rate of almost 61% compared to just 13%, which is how many times? You do the math, at least 4 times, more than 4 times better. And if you look at natural conception, it is 10 times better, 6% versus 66% almost. And there are numerous anecdotal evidences. I'm sure even you have experienced this, that while patients were on AKT, they conceived on their own without any further intervention required from the clinician. You didn't need to resort to expensive, complicated ART, just putting the patient on AKT. During those 9 months, sometimes they conceive on their own, assuming, of course, that there is tubal patency and it was only a pure endometritis, which was at the first. If you look at the forest plots, you will find that almost universally simple treatment with antibiotic courses improves fertility and increases your clinical pregnancy rate as well as your live birth rate. The last 5 minutes of the talk, I just want to focus a little bit on recent advances and future technologies which will be available to us very much in the near future. And this is something which we should all be excited about. And for this, I have a paper. This is published in Biomolecules, April of 2020. And there are multiple researchers here who have looked at modifying the uterine microbiome. Now, we talk about vaginal microbiome quite frequently. We talk about probiotics and prebiotics. We talk about patients with chronic cervicitis. What we don't often talk about is that just like the vagina, the uterus also has a microbiome. The fallopian tubes also have a microbiome. And that is very similar to the vaginal microbiome, but it is unique in its own way. And that also needs to be restored if we want better success rates in these women who have CE. So this is what this paper likes to talk about and to address. And they've seen that what we just said, this role of prebiotics and probiotics in genital dysbiosis, which bacterial vaginosis is very well proven, but studies in chronic endometritis specifically are as yet awaited. We don't have a good, substantial, robust body of evidence, but indirectly we know that BV predisposes patients to chronic endometritis as well. Therefore, prevention of CE recurrence is essential. It's not enough just to give a course of antibiotics and leave them alone. You need to try and restore the uterine microbiome as well. Now, there are various different tests which the pharma companies and the laboratories also will come and they will keep hammering you and they'll give you different acronyms. And just to simplify it, I'm going to put up one slide to make the situation very clear. And most of these tests, ERA, EMA, ALICE, and DICE, are spoken of very commonly at conferences. And if you're a novice and you don't do these tests very often, you can often be left completely confused. So there is a test which combines all of these tests, and that's called the endometrio. And the first is ERA or endometrial receptivity array. This looks at the exact day of the implantation window. As we know today, the implantation window is a very finite and important time when after your embryo transfer has occurred, the embryo is actually going to attach to the decidua, take a blood supply, and it's going to grow. That usually is on day 3 or day 4 up to day 5 after your embryo transfer has occurred. So that's a very critical period, the window of implantation. The theory is that if you know when this particular endometrial lining in this patient is most receptive, you will do your blastocyst or your D3 cleavage embryo transfer at that time to achieve best possible success rates. That's the theory. Unfortunately, in every cycle, the window of implantation is different. For every patient, it is different. And that is where the entire crux of the argument lies. You may not always be able to ideally identify the exact window of implantation in a patient. So again, the principle of your mileage may vary applies. So that's ERA. EMA looks at the endometrial microbiome, which we've just been discussing quite a lot about, and it tries to look at whether the microbiome is lactobacillus dominant or it's non-dominant. If it's non-dominant, obviously you need to give a pre or a probiotic. And lastly, you have ALICE, which diagnoses chronic endometritis. If you combine all these 3 tests, especially if your patient is affording, that's a very big if. And if your patient has recurrent implantation failure, so-called unexplained infertility, where everything is absolutely normal, but you're not able to achieve pregnancy, these are the next step forward. These are expensive tests. They are not advised for everybody, but then these will probably help us to achieve better clinical pregnancy rates in this particular group of women. The vaginal microbiota transplant also you may have heard of, just like you have fecal transplants, which are all the rage, especially in patients who have, say, Crohn's disease or ulcerative colitis, irritable bowel syndrome, inflammatory bowel disease. Sometimes a fecal transplant and changing the microbiome of the gut helps these patients immensely. Similarly, vaginal microbiota transplants have been touted to improve the vaginal microbiome and the uterine microbiome as well. In the years to come, maybe 5-10 years from now, that will be something which will be very much mainstream. As yet, we don't have enough robust evidence to recommend. So, ladies and gentlemen, to conclude, a few simple key practice points. Chronic endometritis is common, especially in women who have so-called unexplained infertility, recurrent implantation failure, and a lot of patients who have recurrent pregnancy loss of first trimester origin as well. There's far-reaching consequences for women's health. Timely diagnosis is required, but unfortunately it's unusual, both because the patient doesn't present to us, plus we ourselves don't have a high index of suspicion. There are several challenges and hurdles to the diagnosis, as you saw that you need to have an endometrial biopsy with a supravital immunostaining technique for CD138 to look for ESPCs to make a 100% foolproof diagnosis. An alternative is to do a hysteroscopy and look for those 5 or 6 different signs that were described by that working group, which reached a consensus. But the key factor that I want to push ahead today is that irrespective of how many challenges there are, to the diagnosis. Treatment is very easy. It's easily accessible. It's not expensive. Even if empirically you were to treat these women with a course of antibiotics and then repeat your hysteroscopy or your biopsy afterwards, you will find that success rates, cure rates are up to 90%. The remaining 10% are patients which are going to be challenging, but if you can help even 90% of the patients with a simple antibiotic therapy, they are going to have significantly better clinical pregnancy rates and live birth rates. There are exciting new developments ahead, of course. There is the uterine microbiota transplant, and sooner or later we'll have some targeted gene therapies also to improve the endometrial receptivity sooner or later. So thank you again for a patient hearing. Thank you, Professor Muralidhar Pai, for this opportunity. I'm open to questions.
Thank you, Pratik. It was very comprehensive and complete. And I really liked your last few sentences. That is, yes, the diagnosis is very difficult. And nowadays, cultural sensitivities especially will not yield sometimes anything. You have to go for higher techniques, but then techniques may not be available everywhere. But if you have got repeated implantation failure, you can always keep this in mind and treat it with simple antibiotic, a course of antibiotic, and you may get a better results. Why not? So, and you have just brought it, so well across to all of us, and that's Pratik always. And now I request Dr. M.G. Hiremat, sir, who is also a infertility specialist down in Karnataka, so to give his comments. MG sir.
Arun, MG sir idara?
He was there initially.
Yes, sir. He left, I think.
Okay, no problem. Okay, no problem. If anybody else would like to give comments, otherwise I request Dr. Rajeshri to conduct the question and answer. Giving her. Yes, ma'am.
This is Dr. Bharti Rashekar. Sorry, I'm in the car. Dr. Pratik Tambe,
Okay.
thank you very much for gracing the Kasoga KCOG platform, and we enjoyed your talk. It was so clear and you have given very good take-home points. Thank you very much, sir, for being with us.
Yeah. Rajeshri, give your comments first and then please conduct the question and answer, if any.
Yes. Namaste, Pratik sir. We always underestimate the prevalence of endometritis and infections as a causative factor for infertility. But being in the Indian subcontinent, as you rightly mentioned, that this is a disease which is unique for us Indians, and maybe it is not as prevalent in the other countries or the Western world, especially the tuberculosis. Sir, there don't seem to be any questions in the chat box, but I have a query. Sir, what is, as of today, the golden test for diagnosis of Mycobacterium tuberculosis?
So the backpack method or the culture test, which takes about 6 to 8 weeks, is supposed to be the gold standard. There are other RNA and DNA amplification techniques also, PCR specifically. But then it is said that PCR can amplify dead bacilli also, may not amplify live bacilli. So there's a little bit of controversy there. Unfortunately, our culture methods, whatever we have, they can never give us 100% foolproof diagnosis. So we usually depend on a combination of both clinical as well as laboratory diagnosis. Remember that tuberculosis is a notifiable disease in most parts of the country. And if you put the patient on AKT, you are required to inform the local health authority. But as far as the genital cough is concerned, we usually have a low index. We have a high index of suspicion and a low threshold for starting AKT. Because when everything else has been tried, that is the only treatment that is available to us. And we clinicians usually like to do something, then not do anything and sit back and say, okay, we admit defeat. We can't do anything. Nothing else is left now.
Thank you, sir. But like in other antibiotics that we give over a period of 1 to 2 weeks' time, is there any role that AKT can be given for a short duration of time and try whether the patients and symptoms will improve? Because many times when we do ultrasound on the 12th day, especially for follicular study, we find that there is a fluid in the endometrial cavity, and which is an indirect evidence of presence of infection in the endometrium. So how do we go about it?
So fluid in the endometrial cavity is something which is quite normal if the patient is on gonadotropins and she has multifollicular development. If you have a patient who's only on oral ovulation, she's not on gonadotropins, and you find fluid in the endometrial cavity, as you said, it may be an indirect marker of infection, in which case, of course, you would like to aspirate it, send it for histopathology, biopsy, smear culture, antibiotic sensitivity. But at the end of the day, we know that if infection is suspected, we in India usually have a low threshold for starting treatment. We don't do all these theoretical tests, which are, with all due respect, described in the textbook and research.
Correct, sir. Yes, sir. Yes, sir. And many times
Another
we find
important
that
thing that we have to remember is that Mycobacterium tuberculosis impacts the stratum basale of the endometrium. It is not seen in the superficial layers. The stratum
correct.
basale is the layer from which all the other layers are regenerated every month because the upper two layers are shed during your menses. If you have an infection of the stratum basale, you are going to require long-term antibiotics. So therefore, if you have genital pox, especially deciduitis, it is recommended to give at least 6 to 9 months AKT. Don't give short course because then what will happen is the patient will have a resurgence and she may land up with multi-drug resistant pox, which is very difficult to treat and very expensive to treat.
Correct. Is there any possibility that we give a short course of antibiotics when we find, for example, fluid in the endometrial cavity, and then recheck her after the next menstrual cycle to rule out whether she has responded to this medication, or should we again do the endometrial aspiration and the sampling and the biopsy before we go ahead for the treatment?
So in an ideal world, you would like to aspirate, do a sampling, prove the diagnosis, and then administer antibiotics. In clinical practice, we rarely do that because even that aspiration and that sampling often is inconclusive. You don't get a smear culture antibiotic sensitivity from that endometrial fluid aspiration. Usually, it's just 1 or 2 ml also. It's not a big quantity, and
Yes, sir.
therefore the
Yes.
yield is quite poor. In such cases, it is recommended to give at least 2 weeks of doxy plus metro. As you saw in my presentation, the patient is somebody who is not able to take doxy because it causes a huge amount of gastritis. You can use ofloxacin plus metro as an alternative for 2 weeks, but you need to give it for at least 14 days as per CDC guidelines.
Yes, yes, sir. We understand that although it is a profound problem, but the solutions are quite simple if we think
Exactly.
with the presence of mind and then give her a proper antibiotic cover for 2 weeks, then a lot of damage to the tune of 25% of infertility and various complications of pregnancy can be prevented and avoided just by timely intervention and extended therapy of antibiotics towards the targeted organisms, which will in a great way enhance the fertility ability of the woman to the tune of 90%, which is a great news for all the practitioners. A very, very important topic, sir, which you have covered so very well and clarified so many doubts and brought up the newer perspectives like the triple test apart from the ERA, which are used in the diagnosis and management of infertility. And everything was covered in a short duration of time. Very, very thankful to you, sir. I think nobody has any more doubts. Sir, Mulidhar, sir, any more doubts from the audience? I don't see in the chat box.
Yeah, it's okay. I think we can conclude the thing. It was very crisp, as you said.
Very,
but
very,
we
yes, sir.
got out all the important points. That is the
Sir,
knack.
I'm really happy I attended this talk and
Yeah.
Muralidhar sir asked me to moderate this session. Grateful to you, sir.
Yeah, thank you.
Thank you, Dr. Mulidhar Pai, for inviting me.
Yeah, Dr. Suman can propose vote of thanks.
Yes, good evening, one and all. And of course, first of all, I would like to thank the entire ACOG team headed by the Chief Patron, Dr. M.G. Hiremat, Dean, Dr. Hema Divakar, Chairperson, Dr. Muralidhar Pai, Secretary, Dr. Vidya Bhatt, for keeping the CPAP going and making it, it's always wonderful to hear from wonderful speakers like Dr. Prateek. I also thank the Kasoga team, headed by Chief Patron, Dr. M.G. Hiremat, President, Dr. Vidya Tobbi, Honorary Secretary, Dr. Rashi Paradhi, and thank you for your inputs, Madam, and President-elect Dr. Bharati Rajshekhar too. And I also thank again Dr. Muralidhar Pai for chairing this session, and I also thank Sir for inviting such a wonderful speaker today. And Sir, I also thank, of course, today's speaker, Dr. Prateek, for giving us the updated knowledge and including the recent advances on chronic endometritis and its impact on infertility. Thank you very much, sir. And I'm very happy that I attended this session, and of course, a very, very practical oriented topic. And I also thank all delegates. Finally, I thank Mr. Arun for providing this Zoom platform. Thank you, one and all. Thank you.
Thank you.
Thank you.
Good night. Thank you, Prateek,
Thank you,
once
sir.
again. Yeah. Bye.
Thank you,
Namaste,
sir.
Dr. Muralidhar.